experience combining intracorneal segment ring and lensectomy with monofocal IOLs in patients with keratoconus. Just in case we run out of time, we will start with the conclusion. Some patients with keratoconus and cataract achieve good functional results in terms of efficacy, safety, and predictability when implanted with segments and monofocal IOL. Besides, a surprisingly unacceptable near vision is achieved with this procedure, clinical impression that we will cover. We start this study with the purpose of assess the refractive and visual results of the sequential implant of a rara ring segment and lensectomy with a monofocal IOL in patients with keratoconus and cataract. We haven't found any study of this matter. We published one article about this, about the efficacy and safety of the procedure in terms of far vision, but we didn't mention yet nothing about the near vision. The study sample that we are presenting included 70 eyes from 47 patients with a mean age of 58 years and a minimum follow-up of 12 months. This is a good example of the sample. This patient has a typical croissant shape, keratoconus and cataract in both eyes. We performed the second surgery, making the tunnel with a femtosecond laser, and 3 months later, the lensectomy is performed as usual, implanting a capsular tension ring and a monofocal IOL. The incision was always made in the steroid meridian, and if required, an opposite clear corneal incision was associated to manage the astigmatism. Our results are summarized in this table. A special mention to visual acuity improvement with and without distance correction, and an efficacy index close to 1, which indicate that the conservative visual acuity without correction was almost as good as the preoperative acuity with the distance correction. Regarding safety index, which compares distance corrected visual acuities pre and postoperatively, was 1.3, indicating a safe procedure. In fact, more than 87% of the eyes improved the distance corrected visual acuity after IOL implantation. The predictability of the sphere was good, with 80% of the eyes in the ±1 diopter range. And for the cylinder, which was assessed using vector analysis, 89% of the eyes were between ±1 diopter of the intended correction. The TIBOS method, plot of J0 and J45, shows how in the beginning square dots compares over the center after the surgery. We have also evaluated the intermediate and near vision of patients with a paracentral conus and an inferior segment of 150 degrees of arc. In these cases, we have obtained a defocus curve showing an acceptable intermediate and near visual acuity. The aberrometric pattern was well defined and very similar in all cases. Our first surprise is that the near vision is better than with a monofocal IOL, and so, being the lens monofocal, the corneal profile obtained has to be responsible for the near vision. The defocus curve is similar to the curve of the size trifocal implant for the far intermediate foci, but worse of the near focus. And the far vision is as well similar to obtain with the Presbymania correction, specifically with the focus curve of the distant vision of a Presbymania treatment. In conclusion, the combined surgery of segment and lensectomy with a monofocal IOL surprisingly allows near intermediate vision. You obtain a multifocal cornea without compromising the visual axis, and the procedure might be reversible, and the topographic and aberrometric pattern will be the target for new studies.